Thank you very much for the invitation to speak today. My job is to give an update on delirium, focusing on the clinical aspects, but I'll also be signposting some areas of research that have been exciting in the last few years. You can see in the title slide that I have put a URL on the 480 website, which will give access to the slides and supporting references. So here are the areas I'll cover today. I'd like to start by covering definition and the interesting developments in terminology that have occurred in the last couple of years, really. So just to recap the 2013 DSM-5 criteria for delirium, the first two, A and B, are the most important. Disturbance in attention is seen as the cardinal feature of delirium, and this can range from somebody who's barely awake and able to pay any attention to you at all to somebody who's hypervigilant. But the essence is that they're unable to focus in a normal way on any kind of stimulus for any length of time. And awareness is a less well-defined construct, but it's said that it's to do with engagement, so somebody being unable to engage appropriately with the environment. Criterion B is also critical to the diagnosis, and this refers to the fact that delirium has an onset of hours to days usually, and this distinguishes it from nearly all other psychiatric conditions. Delirium also has a tendency to fluctuate, although it doesn't always fluctuate. Criterion C is a little bit redundant because where there is disturbance in attention, there is nearly always disturbance in cognition as well if you measure it. It is to do with differential diagnosis only. One thing I'd like to point out is that the guidance notes make it clear that patients who are unable to speak because they're really sleepy or not engaging, that doesn't make them unable to assess. It doesn't give them stupor or obtundation. They're still eligible to be called delirious because this is said to indicate severe inattention. And this is important because without this, it means that some tools that rely on interviewer cognitive testing may give the wrong result. Ken Rockwood had this memorable phrase, terminological chaos, a few years ago, and that's still the case really, with lots of different terms which you can see in this slide which have been used to describe essentially DSM-5 delirium. This has a lot of consequences in clinical practice and in research. We did a study recently showing almost complete segregation of the delirium and encephalopathy research literature. Papers 1990 to 2018, the red ones are delirium and the blue are encephalopathy. And you can see there is a few clusters of encephalopathy work, but only one cluster of delirium and almost no overlap between the two. This issue was addressed by a group of people who got together and using a Delphi process made some statements that we agreed on, and then this was agreed to by 10 prominent societies, including neurological societies and psychiatric societies, to come up with what are the recommended terms in 2020. So delirium is the clinical syndrome. Coma is also a clinical syndrome, and underlying that is acute encephalopathy, which, to be clear, is not the clinical syndrome, but it's referring to the pathobiological process which leads to the delirium or the coma. The group also recommended stopping the use of the terms altered mental status, acute confusional state, acute brain dysfunction, or acute brain failure, because these to some extent overlap with the terms on the left, but they create confusion if you use them. So we advise that these terms are not used further, just delirium, coma, or acute encephalopathy. Mark Oldham, who's a psychiatrist in Rochester, New York State, brought together these ideas, thinking that it would be good to emphasize that the encephalopathy underlying delirium should be integrated into the construct of delirium using the term delirium disorder. And this is a very thoughtful piece which describes the traditions that have led to the separation of encephalopathy and delirium and an attempt to bring them together. I'd like to go through some of the fundamentals and developments in epidemiology of delirium. One thing that's really clear is that delirium is now definitely seen as a major part of the workload of acute healthcare systems, with double-figure percentages in nearly all settings. And I think this has been underappreciated, perhaps because delirium has been distributed among lots of different wards, but it's very important that any attempt to look after this condition does appreciate the size of the burden and the fact that it's distributed throughout the hospital. These risk factors are some of many that have been studied, but the ones that tend to come up again and again in studies. And I'd just like to highlight frailty, which is a relatively new construct appearing mostly in the aging and geriatrics literature. And that's emerging as a very strong risk factor for delirium alongside these others. Of course, there is some overlap among these. It used to be thought that delirium was a benign and transient condition, that simply was an epiphenomenon or a consequence of a more serious illness like pneumonia or something like that. In fact, delirium itself has a lot of serious consequences, some of which are short-term and some of which are long-term, and this has been shown in multiple studies now. And I'd just like to highlight severe distress as being something that I think up until recently hasn't really been recognized as an important consequence of delirium. One of the most important developments in the field in the last few years has been the recognition that delirium is a strong risk factor for future dementia. This paper here is one of the first big papers in the field to show this. There are now many others. And this paper found that in patients without known dementia, and this was a prospective study, so people were assessed for dementia at the onset of the study, that episodes of delirium conferred a massively increased risk of future dementia, the odds ratio being 8.7. We also know that delirium episodes may accelerate the decline in existing dementia, as shown, for example, in this study by Fong et al. In 2009. Another important set of findings is to do with the fact that although in around 80% of cases delirium does resolve completely, although it still may have a risk of dementia in the future, some delirium persists. And in this important study in people without known dementia, those patients who did not fully recover from delirium had much worse outcomes, for example, survival over time. And this condition, persistent delirium, is kind of invisible. Probably not, I would say, to psychiatrists or geriatricians, because we see it as part of our day-to-day work, but it's not really understood and often confused and mixed up with dementia. I'd like to cover some basics of pathophysiology briefly. And this diagram is simply to show in simple terms what we're dealing with here. So on the left, we have the triggers of delirium. In the middle, we have the acute encephalopathy, the brain disturbance that is underlying the delirium. And on the right, we have the clinical syndrome. So the job of the pathophysiology researcher is to understand what's happening in the brain as a consequence of these triggers on the left and how it yields the clinical syndrome on the right. This is a diagram mostly constructed by Colin Cunningham, who's one of the leaders in the field, in a recent review. And this diagram attempts to bring together the predisposing factors, or the vulnerabilities as they're called, the acute cellular changes that might be happening during delirium, and the functional consequences. And you can see that it covers on the top left the inflammatory processes that might be leading to dysfunction and injury, perhaps leading to both the syndrome of delirium and future dysfunction and dementia. The drugs that are known to be triggers of delirium there, perhaps interacting with deficits in the reticular ascending arousal system, which are known to be happen with aging. The systemic triggers at the bottom, which are known acute factors for delirium, and so on. But I think it's well worth, if you're interested in this area, looking at the review, which goes through these different pathways that have been supported by research over the years. Now, one of the things that's a real priority in the field is to try and understand the relationship between delirium and dementia. So it used to be assumed that delirium was simply a reflection of vulnerability, that there was already dementia pathology in the brain and this was simply uncovering it in some way. But a second set of ideas is that during the delirium, during hospital admission, during the illnesses that cause delirium, that there is actually brain injury happening at that time. And those of us who see patients with delirium in hospitals will recognize that many of these things that I've shown in the slide there are occurring. Hypoxia, especially in the COVID era, is really common. The stress that people are undergoing, and we know that the cortisol levels can be very high in people in hospital who are unwell. the lack of stimulation, the sleep deprivation. There are many different threats to the brain in people with delirium that could very conceivably be causing damage at the time and also maybe triggering processes that lead to dementia in the future. And there is some supportive evidence of this idea. This study looked at animals with and without underlying neurodegeneration, and systemic inflammatory events over time caused marked declines in progression of the disease in those animals with pre-existing neurodegeneration, but no decline in animals without neurodegeneration. There is some work in humans on this. This is one of our older studies looking at the pro-inflammatory cytokine interleukin-8 in the CSF taken at the time of spinal anesthesia in hip fracture patients, and this showed higher interleukin-8 in the CSF in these patients with delirium. And other studies have found similar findings. An exciting development in the last couple of years has been studies of neurofilament light. This is a marker of neuroaxonal injury. And in this study, where the neurofilament light was the same at baseline in people who became delirious versus those who didn't, at postoperative day 1, those that became delirious had higher levels of this marker, and it persisted over several days. So in summary, it's important that we see delirium as a brain disorder, which is kind of obvious, but I think it maybe in the past hasn't been seen that way, perhaps in the same light as other forms of brain injury. Obviously, there's going to be multiple potential mechanisms given the range of triggers. Some of the causes are obvious and direct, like hypoxia, hypoglycemia, drug toxicity, but there's likely to be a large collection of indirect causes, with peripheral inflammation and stress being among them, where maybe there isn't an obvious way to see this at a clinical assessment. A priority for pathophysiology research is not just to understand what's happening in the brain during delirium, but also how it is that delirium has this massive association with future dementia. For now, I think the implications of this are that we need to think of the brain as being very vulnerable in people with delirium, especially, or in older people who are at risk of this, and to protect the brain through maintaining good oxygen levels, nutrition, all those different factors, as well as, in parallel with this, researching new ways that we might be able to protect the brain. Now I'd like to move on to clinical care. So these are the 3 fundamental processes that I'll be talking about: diagnosis, treatment, and prevention. So to help understand the challenges of diagnosis in the clinical setting, I'm just going to present 2 simple scenarios. So scenario A is at the front door, an 86-year-old man who's come in with pneumonia. And it's very important that we know whether this man has delirium or not. He's clearly at very high risk, and guidelines recommend that we assess for delirium in this kind of patient at the front door. The second scenario is monitoring for new delirium. So this scenario is a person in hospital who doesn't have delirium, but who is at high risk of it because of background factors and perhaps acute factors too. And we do see quite a lot of delirium that arises after admission. So we need to have some kind of process that monitors for this in vulnerable patients. So I would say that delirium detection in clinical practice involves 2 basic processes. On the left, episodic tests, and these are to be used at the front door where there's transitions of care or when delirium is suspected. These tests need a good balance of sensitivity and specificity, and I think we do need to be pretty close to providing a diagnosis, but my opinion is that a tool can never on its own provide a diagnosis. It's always a clinical decision. But these tests are done now and again, they're not done frequently. It's different when you think about monitoring tests, because these have to be done repeatedly in people who don't have delirium, and they're done usually 1 or more times per day. The tests need to be sensitive, but I think they do need to largely be observational, because otherwise you're in a situation where patients are getting repeated cognitive tests like months of the year backwards or digit span, and over days and weeks, it's just not feasible for the patients or the staff to repeat these. If these tests are positive, then the idea is that this progresses to an episodic test or a clinician diagnosis. So these are tools in wide clinical use. The 4AT and the CAM are the chief tools used as episodic tools. And on the right, there's a list of other tools which are used in clinical practice. I'd just like to point out that the CAM is used as a monitoring tool, but it's often done without a cognitive test and interview. And this, unfortunately, has shown low sensitivity. The 4AT has emerged as a commonly used clinical tool, and we did a recent systematic review finding that it has a good body of validation data. You can find out more information about this at the website, the URL's there. So now to move to monitoring tools in a bit more detail. So as I said, there are many that are being used, and some of them have validation data and others don't. But I would say that this is an area where, in fact, the clinical practice has gone ahead of the research, with several processes being used, but without much information, the performance of such processes. And we really do need to do some implementation studies and just check that processes that are being advised are actually working. This is one example of a widely advocated monitoring system, and this uses the National Early Warning Score version 2, News 2. And you can see in the top picture that there's a confusion row, and this was brought in 2017. And this was meant specifically to look for delirium. And the guidance from the Royal College of Physicians is that if there is apparent new confusion, that the practitioner is advised then to do a more definitive test, in this case, the 4AT. Now, the diagnosis of delirium isn't enough, because diagnosis is based on change and inattention mostly, or level of arousal perhaps. But delirium is a rich and heterogeneous syndrome, and knowing the features of an individual patient's delirium is very important for us to understand how to look after them. For example, noting if they're frightened, if they've got psychotic features. So it's not just about the diagnosis, it's about assessing the features once that's done. Now I'd like to move on to treatment. Now, despite the fact that delirium is a major problem for healthcare systems, in fact, it's amazingly under-researched with respect to trials of multi-domain delirium treatment. By multi-domain delirium treatment, I mean ordinary delirium care, which is looking at triggers and using various ways to help the patient recover. There are only 3 RCTs. The Pitt-Calla papers refer to this to a single RCT. There are a small number also of QI-type studies. The kinds of interventions that have been tested include consultations by specialists, algorithms and order sets, education of whole units, and so on. The results are mixed, and in fact, the conclusions of most reviews is that they haven't shown definitive proof that multi-domain delirium treatment, the mainstay of delirium care, actually works. But because it obviously does in some cases, the consensus really is that this is something that we should do. What we don't know is how to do it. The SIGN guidelines, which were published in 2019, tried to bring together some aspects of good practice drawn from different guidelines and from consulting with experts. And this Delirium 8 scheme draws from the recommendations in the SIGN guidelines. And I'm just going to go through this briefly to show the different ways that we should approach delirium treatment, considering all the different aspects, because it is quite a complex condition to treat. So the first one is in red, and that's an initial check for acute and life-threatening causes, because people with delirium often have hypoxia or hypoglycemia or some other acute cause. And sometimes this may be not recognized because the patient is just seen as being confused. So it's always good to just check, is there something really serious going on at the time? The second part of delirium 8 is to identify and treat causes. And the idea of treat the cause, of course, it's essentially correct, but the flaw with it is that there often are multiple causes. So every time somebody has delirium, especially if they're older, it's really important to be systematic and look for the multiple different causes that you might see. Part of that is also optimizing conditions for brain recovery, and that involves, for example, making sure that somebody doesn't become dehydrated, and so on. The next aspect of delirium 8 is specifically to go and detect and treat distress. And this was written by somebody with delirium in intensive care, and it shows this, and many other accounts show just how terrifying and awful delirium can be for the person who's experiencing at the time. So I think this is something in my experience that isn't done all that well, perhaps because it isn't necessarily part of existing delirium pathways. So the process I would suggest is that whenever somebody looks distressed, restless, frowning, unhappy, find out why, looking for reversible causes like the ones on the left, including urinary retention, which is a really common cause. And sometimes I've seen people given haloperidol because they're restless because they've got urinary retention, and obviously it hasn't worked. So you need to really look at the triggers and try and work your way through them and see if there's anything that can be fixed. And in parallel with that, because sometimes you can't fix the distress, even if you know the cause straight away, to treat the distress specifically with reassurance, involving the family where possible, one-to-one nursing, and sometimes by using drugs. So lots of studies have been done on the use of drugs in delirium, lots of RCTs, and there's actually so far no evidence that treating delirium with a drug, when you consider delirium as a whole, works. Yet we still see this being done when somebody has delirium, that somebody just prescribes haloperidol or something like that. But actually, that doesn't reflect the evidence. And in fact, it may well be risky. So in my opinion, drugs should never be prescribed just because somebody has delirium. However, I do think that there is a role for drugs if there's severe distress or danger. There isn't evidence of this, but there is good expert consensus that there is a role in people with severe and intractable distress, perhaps using antipsychotics or where necessary, using benzodiazepines. One thing that I also see, and which is documented in studies as well, is that sometimes these drugs are started but not stopped. And so even people can go home on them. So it's very good practice to keep a patient under review and consider stopping the drugs after a day or two. Often I think that's enough, because by that time, hopefully, the rest of the delirium treatment is becoming effective. So I'm not going to be able to go through the other aspects in detail, but just to mention that we know that delirium is a risky condition. People get pressure sores, they get malnourished, they're immobile. So when you have somebody with delirium, consider them at high risk of these complications and do what you can to mitigate that. We also know that communication is often poor, with families left in the dark, perhaps because delirium hasn't been diagnosed, or perhaps because the team hasn't told them that this is delirium. Otherwise, they're left with all sorts of, confused ideas about what this might be. Is it new dementia? Is it something else? People with delirium usually get better, but some don't. So it's also really important to document the progress of the delirium. Is it getting better? Rehabilitation is a potentially really exciting area of the field, with an increasing interest from several groups of staff, notably occupational therapy, where this involves engagement with the patient, trying to restore normal functions during the delirium and also after the delirium if the person's still not quite back to the normal self. The other very important area of delirium care is to consider dementia, because many people with dementia develop delirium in hospital, but the dementia is sometimes not diagnosed. And also, as I've said before, because people with delirium who don't have dementia have a high risk of developing in the future. And this study showed that it's actually possible to do something like the Informant Questionnaire of Cognitive Decline in the Elderly, the IQ code, during an episode of delirium to flag up the possibility of undiagnosed dementia. And then this opens the gateway to follow up at an appropriate time, perhaps 3 months after discharge. So now I'd like to cover prevention. So this is actually one of the better evidenced areas of delirium care. The original big study was in 1999 in the New England Journal, Sharon Elway's HELP protocol, and this involved 6 domains of intervention. This was enhanced in 2013 because the NICE guidelines had updated the evidence and found that there were other elements which could lead to delirium if not addressed. Something that's important to understand about HELP is that, yes, it is effective, but it does require volunteers, and many centres have found this quite challenging to implement. HELP also costs quite a bit of money to subscribe to the programme. So a systematic review published last year looked at 8 RCTs, 3 of which were health-based, and this did find a strong effect of the efficacy of delirium prevention for delirium risk. And importantly, it found that, yes, of course, help works using volunteers, but it's not necessary to have a protocol based on volunteers. The SIGN guidelines showed a list of the kinds of things that might be implemented for delirium prevention. So my take on all of this is that if you wish to implement delirium prevention using help, that's fine, that will work. But there are other ways to achieving this. And actually, quite a lot of it is having systems in place, mostly around nursing care, that avoid iatrogenic harm. So making sure that somebody has enough food and water, making sure that they're mobilized, that they sleep, that they have access to their glasses and their hearing aids, and so on. So to conclude, I'd just like to talk about some of the ways in which I think the field might be going in the next few years. The big thing really, I think, at this stage is to implement better care. So if you take the 3 fundamental aspects of delirium treatment on the left, we know that even though we've got good processes that are usable in clinical practice to diagnose delirium, that in most healthcare systems, less than 30% and even less than 10% in some is diagnosed. With respect to treatment, this is difficult because we don't really have strong trial evidence, just expert consensus. But partly because of this, we have a chaotic state of affairs with specific delirium treatment not being done in many cases, or in an incomplete way in many cases, often because there's no diagnosis, of course. With respect to prevention, there's been good progress in this, but unfortunately, there are very few implementation studies that I've seen. So mostly known preventive strategies that are known to work have not been implemented in clinical practice. So these are, I think, some of the big priorities for clinical care. Now, to achieve this, one of the key insights over the last few years has been that because of the complexity of delirium, because it involves quite a lot of engagement between staff and patients, not just a single intervention, it requires a lot of work to make a system get better at delirium care. And I've shown on this slide some of the key elements. At the top left is education. And I think this is probably the single biggest priority. We know that education works. There are a number of reviews showing this. And we also know that education has to be covering different domains. So not just providing basic knowledge of delirium, how common it is, for example, but also the skills and bedside assessment and treatment. And importantly, attitudes and culture. For example, it's known in some studies that staff maybe don't understand who owns delirium, who's responsible for its care, when in fact, just like many other conditions are distributed around the hospital, anyone who's coming into contact with delirium owns it at that time with the patient. So that's the kind of thing that needs to be worked into any education program. And patient experience is a very important way of getting this across. Other methods of improving delirium care are listed there. I'd just like to mention standards, the NICE guidelines, the SIGN guidelines. Setting standards and auditing those is a very important thing. Having institutional knowledge and support is also critical to get things up and running. In the UK, since the NICE guidelines in 2010, there's actually been a very concerted effort with multiple major educational events, initiatives, lots of in-hospital ones as well, introduction of screening tools, including the 4AT, which we now know is used in more than 80% of hospitals in the UK. And I'm pleased to say that we are beginning to see increases in delirium coding across the whole hospital system, both in Scotland and England. So these are not studies, this is the whole population using the public health databases. And we see large increases from under 4% to above 15% in over 90s in Scotland, for example. The increases are less in the younger age groups, and still overall we're underdiagnosing delirium, but it's encouraging to see that all this work to create standards, to do educational events is beginning to have some kind of effect. There are many ways in which I think delirium education should go. We still need to learn a lot more about the epidemiology of delirium. For example, we don't really know why some people recover from delirium after a couple of days and others will develop catastrophic, prolonged delirium that may never fully get better. We don't know much about how to implement delirium treatment in clinical practice. And I think based on something like Delirium 8 with SIGN guidelines, it's really important that we develop standardized ways of making sure that those different targets of delirium treatment are hit with patients so as to improve the outcome. Obviously, given the massive relationship between delirium and future dementia risk and the multiple plausible ways that the brain could be being injured in patients with delirium in hospital, it's very, very important that we learn more about what is linking delirium with dementia at the mechanistic level. This might then lead to efforts to make sure the brain is protected during acute illness. But I think on top of that, there is great potential for drugs that may, for example, prevent inflammation in the brain. And already some studies are beginning to look at this. The final big part of research, which I think we need to look at, is specific trials of use of antipsychotics or other drugs for distress within delirium. So instead of doing treatment trials where you give haloperidol or risperidone for delirium, consider it as a syndrome that you select those patients with distress and then test whether risperidone or haloperidol works alongside other clinical measures. So just to conclude, I'd like to let you know about the World Delirium Awareness Day, which is on the 17th of March, St. Patrick's Day this year. And this is going to be bigger than ever. We've had this for several years now, but this is going to be bigger than ever with 36 hours of delirium education on a YouTube channel and daily lectures and other events on delirium called the Delirium Marchathon. And you can see Twitter to find access to the website that's providing that. So most of this has been done through Twitter. So do look up that and follow those Twitter handles if you want more information. The other thing to advertise is there are now 3 big delirium societies, international societies around the world, and each of these is having a meeting this year. The American and European ones are virtual only. The Australasian is going to be combined, but the prices are very reasonable, and it's a fantastic opportunity to get up to date with all the different developments. So I'll stop there and thank you very much for your attention.